Hello, everyone. My name is Mars Lombardi. I use they, them pronouns, and I am a medical speech-language pathologist as well as a patient advocate. And today I'm going to be talking with you about the transgender, non-conforming, and intersex communities as it pertains to EDS and mental health. I do not have any disclosures. And I do just want to put up a content warning. Some of these topics may be difficult to discuss, and I just want you to take care of yourself as you see fit, even if that means excusing yourself. So the first thing we're going to talk about today is laying the foundation with some important terms. I think there's a lot of confusion over the terminology that's used in conversations about gender and sexuality and what means the same and what means different and all of these different things. So I just want to put some words out there, some terms, and discuss what they mean in the context of this setting, so that we all know and are on the same page. The first thing I want to talk about is intersectionality, and this is going to be something that Dr. Akila Kadei talks about in another presentation this session, but you can't really have enough intersectionality when you're having these conversations. So I'm going to introduce it now. Intersectionality is a term that was coined by Kimberly Crenshaw, and it was initially utilized to really describe a framework of oppression against Black women at that time. But over the years, it's really become a way to explain how multiple identities interact and create these unique patterns of oppression. And if you look at this graphic on the side that was adapted from the Wheel of Power or Privilege by Sylvia Duckworth, it shows that intersectionality is a very, very broad concept, and encompasses a lot of things like immigration status and income and language and mental status and race and religion. And it demonstrates these power structures and the ways in which populations can be systemically pushed into the margins or oppressed. Another term that I want to just unpack a little bit, because I think that it is really important, especially in the medical community, is sex assigned or assumed at birth. And this refers to the legally denoted sex assigned to a newborn child. And that's really based on their external primary sex characteristics. So this doesn't have anything to do with an individual's gender identity, but it is often conflated with such. So we need to be careful about that when we're having conversations about gender, because sex assigned or assumed at birth is not the same as somebody's gender, or it may not be the same as their gender. So I want to now talk about the term intersex. This is probably one of the least understood terms across the general population. And it's an umbrella term for unique variations in reproductive or sex anatomy. And these variations, I think most people think of as being just genitalia or internal organs like testes or ovaries. And it can be that, but it can also be variations in someone's chromosomes, or even something as simple as hormone levels. Um, and sometimes we are able to identify these intersex traits at birth, and sometimes in situations where it may be hormones or chromosomes, they may not be discovered until puberty or possibly even later in life. But this is an important concept because intersex individuals have been subjected to a lot of medical trauma historically, where they are not fitting into the gender binary of male and female. And in many, many cases, and it's rarely discussed outside of the intersex and queer communities, many children as newborns were subjected to surgeries to essentially fix the fact that they were intersex. And, the decision of, okay, are we going to make this person female or male was really largely in the medical providers' hands, because oftentimes they wouldn't even have those conversations with families because they were afraid that the parents were just going to be like disgusted or upset. And so they would just make a determination based on, okay, this baby looks, more externally male. Okay, we're going to make them male. And, I would like to just make sure that we're all on the same page that that is not okay. And that intersex people don't need to be fixed. There's nothing wrong with them. It is a variation. It's a medical binary that really is at the heart of the issue here. So let's go to the next slide. So a few other ones. These may be more familiar to people. Cisgender is describing individuals whose gender identity corresponds with the sex that they were assigned at birth. So if you were born and your birth certificate says female and you grow up and you identify as female, you are cisgender. Transgender is an umbrella term that describes individuals whose gender identity differs from the one that is assigned to them at birth. So this is a much more broad term. And then gender nonconforming, sometimes people prefer to use the term gender expansive or gender queer. They have slightly different meanings. Today, I'm giving you the definition for gender nonconforming, but this is essentially referring to a person's appearance or behavior that does not conform to society's gender norms. So what I really want you to take away from this is that gender is less like a male-female binary, like on the top of this graphic, and it's much more like a spectrum with all sorts of variations and colors and wonderful things. And that's really what we need to focus on. So getting into mental health challenges. All patients with EDS have a risk of experiencing mental health challenges. And, some of the more common things that we hear talked about are depression, anxiety, self-harm, suicidal ideations, suicide attempts, and unfortunately, successful suicide. And this this makes sense. EDS is a diagnosis that comes from many years of seeking the right health professionals. In many cases, we still have an average diagnostic timeline of around 12 years, which of course is something that we're hoping to change. And I think we will change. But right now, it's a long haul for most people. And it's a chronic illness that often is associated with chronic pain. And these can absolutely contribute to changes in neurochemistry that can contribute to depression and anxiety. But there's also external factors like trauma. And some of that trauma, unfortunately, is happening within healthcare that contribute to these mental health challenges in the EDS community. So if we focus in a little bit more on the trans, gender nonconforming, and intersex individuals with EDS, they have higher risks for these mental health challenges. So why is that? Well, what I'll tell you, it is not gender identity or sexuality that is making somebody high risk. Being trans, being non-binary, being intersex does not inherently put somebody at higher risk for developing mental health challenges. This is not about an internal issue. This is about systemic inequities, like discrimination and gaslighting, a lack of support, a lack of safety, and oftentimes a profound sense of not belonging. And these all contribute on top of what somebody is experiencing with EDS to a sort of compounding effect. when it comes to mental health challenges. And we will look at some statistics in a minute. These risks are then further compounded, if we want to look deeper into this, for individuals who are not white. And this takes us back to that intersectionality wheel of power and privilege. So if you exist at the intersection of multiple systemically oppressed populations, you are more likely to experience medical racism, colorism, even more gaslighting. And then the bigger issue becomes the lack of representation and the lack of medical research. Um, there's just not a lot out there talking about individuals who are Black, gender nonconforming, and have EDS. Um, so there needs to be more research to help um, to include people in moving forward with EDS research. So here are some statistics. These are not statistics that I am happy to share. They're pretty awful, but I'm grateful that the Trevor Project does this survey of mental health of LGBTQ plus young people. So these are the results. These are some results. I tried to pull results that were most reflective of trans and non-binary experience. Um, and I want you to also just know that these results are for individuals in the US age 13 to 24. And this is another issue that we have. This is the largest sort of age group that we have data on. The older we get into LGBTQ plus as a whole populations, but particularly trans, gender nonconforming, intersex populations, the older we get into generations, the less and less data there is. And part of that has to do with safety and not wanting to talk about things because it doesn't feel like it's safe to disclose information. Some of it has to do with just the culture of the times and not being something that was discussed. So these are not reflective of our communities as a whole. Like, my age is not considered in this data, but I think it's still very important data because our young people are faced with a lot these days. So I'm just going to read a few of these. 39% of LGBTQ plus young people seriously considered attempting suicide in the past year. And that's a big number. But then if we look at just trans and non-binary young people, that number goes up to 46%. And then it was also noted that youth of color reported higher rates than white peers. So again, we're getting into that intersectionality, being at the intersection of multiple systemically oppressed identities. 50% of LGBTQ plus young people wanted mental health care, but were not able to get it. This is an issue. More than half of transgender and non-binary young people found that their school, if their school was gender affirming, they had lower suicide attempt rates than those who did not have schools that were very supportive. So this shows us that support matters, gender affirmation matters, and I also want to draw attention to the fact that there are young people and their families that are reporting that they've considered moving to different states because of politics and laws, which is especially relevant right now in the United States, unfortunately. So I'm going to move to the next slide, and we're going to talk about the factors that are contributing to these statistics and these mental health challenges. So transphobia is a big one. It's rampant, and it's incredibly problematic. A lot of it stems from lack of knowledge. Some of it stems from just hate. Um, Pathologizing of intersex existence is one that I think is really important. As I already talked about, intersex populations have been subjected to a lot of medical trauma. And that isn't something that just disappears overnight. It's not a fear that just leaves us. So that is contributing to mental health challenges. Misgendering, so making assumptions about somebody's gender and getting it wrong, is a huge problem. Microaggressions, is something that most people are generally familiar with, but I think people still don't understand sometimes when they're doing it. A microaggression is not like overtly looking at somebody and saying, "I don't like you because you're trans." Um, it can be body language. It can be as simple as just a look. It can be a sort of off-color statement, that's not, the same as saying, like, "I don't like you," but it 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 gives the tone of that. Um, Intrusive questioning, you don't need to ask people, about their bodies, unless it's for a medical reason. And even when you're doing that, you should be doing it in a polite, appropriate, and in the least intrusive way possible. Um, Discomfort during physical medical examinations. This is something that health professionals really need to be aware of. I bind every day. So when I'm asked to take my binder off because a certain part of my body needs to be evaluated, that is extremely uncomfortable for me. And when your body does not, when you have not surgically transitioned, and even if you have surgically transitioned, in some cases, there can just be a lot of uncomfortable feelings sharing parts of your body. So it's important that we are aware of that. Um, the medical model really only refers to gender as a binary. And it largely equates sex to gender. So there's oftentimes, I'll fill out paperwork and it asks me to put my gender down and then gives me the choice male or female. Um, the paper is not actually asking what my gender is. They're asking what my sex assigned at birth was. Or and that's it's a misuse of vocabulary. If they want to know my gender, I'm going to need a lot more options than male or female. Um, and just a general lack of knowledge. We need to have more professionals who don't necessarily work in specifically gender affirming care areas like, providing hormone therapy or doing gender affirming surgeries. But it's still important that professionals understand how to work with trans, gender nonconforming, and intersex patients. And then I have a whole list of things that have to do with our political atmosphere, which is very relevant in the United States right now. So there's a lot of legislation and proposed legislation that is particularly targeted at trans populations, but also in general, the LGBTQ plus population. This has also kind of given people permission or felt like it's given people permission to just use general hate rhetoric. Um, there can be restrictions for patients trying to travel to safer states for care due to their own physical limitations, insurance coverage, um, finances. Um, and it can also impact people traveling to the places that they need to go, to the specialists they need to see, if the states that those professionals are in are considered not safe for trans people based on legislation. Um, And there's a lot of concern about safety pursuing gender-affirming care or about presently being on things like hormone replacement therapy because of things like medical red flagging when there is such a hostile political atmosphere. So, what can health professionals do to support these patients? Well, the best way to show that you're a safe person is to listen. If your patients feel safe, they will tell you what they need. And it's important to understand that being a good clinician is not just about your knowledge of medical literature. It's important, but it's not the whole picture. Ask, listen, and be open. Here's an example of a question that you might be able to ask to sort of show yourself as a safe person. What can I do as a provider to make this space feel most safe for you? And that leaves it open for your patient. So, a few more tips. Introduce yourself using your pronouns. That already shows that that's something that's on your mind and it opens a door. Ask your patient what name they'd like to be called and what pronouns they use. If the name and pronouns provided do not match what is in your EMR, ask if the patient would like that information added because they may not want it added if other family members have access to that information and maybe they're not out. If you make a mistake, correct it quickly. Don't draw more attention than necessary. You don't need to make a whole apology about it. Just fix it and move on. Be extra mindful if a patient has somebody with them at an appointment. If you're dealing with minors and they have family in the room, follow their lead on name and pronouns to avoid accidentally outing somebody. We never know what the family dynamics are, and in an appointment is not the time to find that out. And then most importantly, learn about the history of trans, gender nonconforming, and intersex communities, because that is the best way. And I have a list of resources and books that I can provide. And here they are. And then I'm a book reader. So I figured I would include a list of some nonfiction, fiction, and a poet for those of you who love poetry. And I'd like to end here. This is a piece of artwork that my partner Teo created for me about trans love. And this world is really hard right now. And I don't really know what else to say other than it's really hard. So we need to take care of each other. That is the most important thing. That's the way that we get through this. So take care of each other. And thank you very much for your attention.